sometimes we refer to essential thrombocythemia and polycythemia vera as indolent MPNs. I'm not sure that's always the fairest term for these diseases. They are of the same group of hematopoietic stem cell-derived malignancies. They are chronic and progressive and can shorten the lives of patients, both with ET and PV. Although they tend to have a less aggressive course in general than myelofibrosis, some patients can have significant symptom burden, complications, transformation to myelofibrosis or acute myeloid leukemia, or even early fatal events. So the approach to treatment of ET and PV is risk adapted based on variables that usually are related to advanced age, history of thrombosis, leukocytosis, mutation profile. And risk calculators can be used, for example, the IPSET for essential thrombocythemia. And these risk categories of low and high risk disease will help determine whether patients should have cytoreductive therapy. And the main goal of cytoreductive therapy, at least in 2022, remains reduction in risk of thrombosis. There are drugs like interferon alpha 2A and interferon alpha 2B, Ropeginterferon, that have significant emerging data suggesting the potential for disease modification and disease course modification, which is needed in both ET and PV. And I think the discussions with the patients surrounding what are the goals of treatment and the expectations are really important, because although patients with ET, for example, have an age and sex match disease survival that is similar to a normal cohort, in some studies, these patients can still have significant morbidity, and that must be considered and addressed appropriately. So there's still a lot to be done with these, quote unquote, indolent MPNs.